Today we presented further results from the MANAGE trial. The MANAGE trial randomized patients who had myocardial injury after non-cardiac surgery to receive either dabigatran 110 milligrams twice daily or placebo. We have previously demonstrated that dabigatran reduced the risk of major vascular complications with a hazard ratio of 0.72 with no excess of major bleeding. Today we undertook further analyses because 46% of patients in the dabigatran group had permanently discontinued the drug and 43% in the placebo group. This mainly was at patient request, so we wanted to know if patients were truly compliant, what was the real effect that one could anticipate. And what we demonstrated was that the treatment effect for major vascular complications was even larger. It was about a 45% reduction, and that mortality was significantly reduced, myocardial infarction was significantly reduced, and so was venous thromboembolism. However, the arterial events were tenfold more common than the venous events. Moreover, in the per-protocol analyses, ISTH major bleeding increased, as did lower GI bleeding. However, we prevented twice as many major vascular events compared to bleeding events that were caused. We've done research that we published just in the last few months on this question of what is the underlying mechanisms. Some perioperative myocardial injuries are thrombotic events. Probably about 1 in 8 of these events start off as thrombotic events. However, the majority of these events appear to be type 2 myocardial infarctions and injuries. Importantly, though, the vast majority of these patients have underlying significant coronary artery disease and are susceptible to recurrent major vascular complications. And that is why we think that dabigatran in this setting helped these patients to prevent the recurrent events, even when in fact it was a type 2 myocardial injury, and they definitely could have obviously helped the type 1s also. Our group is putting a lot of focus into the issue of monitoring patients after surgery using remote, automated, continuous, non-invasive technologies. The reason for this is that patients after surgery are all receiving narcotics in their post-anesthetic, so they don't have normal alert mechanisms to detect that something is wrong. Most patients on most surgical floors probably get their vitals checked every 6 hours, and we're just hoping that the nurse happens to arrive shortly after the patient becomes hemodynamically compromised and that they detect it and they treat it quickly. We believe with testing remote automated continuous non-invasive monitors with early alert mechanisms that in fact there's enormous potential to improve outcomes in the exact same way we've had dramatic improvement in the operating room with improving overall mortality in the operating room. We believe we can do that in the post-operative setting on the surgical floor, but also into the home setting. 6% of adults will be readmitted to a hospital within 30 days of their surgery, and we believe if we were better monitoring them at home, we could likely detect the complications much earlier, intervene much quicker, and prevent readmissions and very serious complications. So we think that there's a big role for remote automated non-invasive technologies on surgical wards and in the home setting, but much more research is needed to establish how to use this effectively.